Okay, so we really are on somewhat of a tight timeline, and so I want to get in as much as possible today. You met me earlier. I'm Bunny Ellerin, and today's panel is going to be on a topic that isn't addressed all that much at many conferences, and it's on pricing. How did we get here, and how can we reverse the trend? And so a few things. Number one, it's not about drug pricing, all right? So if you came here only to hear about how bad the pharma industry is, you probably want to go to panel 4, because that is not the point of today's panel. Today's panel is really to talk about pricing across the ecosystem. And as we know, healthcare is almost 20% of the economy and comprises many different parts, right? So there's pharma, services, physicians, and all of the others. So that's really what today is. The other thing is we want to have a civil conversation about it. We are not here to malign any one part of the system. We really want to have a constructive conversation because we are all in this industry and want to see it do well, right? We love healthcare and we want to see it do better. So with that in mind, oh my gosh, look at what I did. Okay. No? All right. So with that in mind, I wanted to introduce the panelists. And I'm going to ask them to each briefly, and when I say brief, I mean briefly introduce themselves. So let's start with Patrick Davish.
Hi, I'm Pat Davish, and I work for Merck, the pharmaceutical company. I'm in charge of pricing, and I'm a lawyer, so you can call me Darth Vader. But I really believe strongly in what we do. And fun fact, you heard from the IBM Watson lady that there are 1,000 immuno-oncology clinical trials going on. Merck is responsible for 600 of those clinical trials for our product Keytruda. Just a fun fact. We'll talk more about it. Thanks.
Nice.
So I'm Jerry Anderson. I'm a professor at Johns Hopkins University. Been there for 35 years because I couldn't find another job. Enjoying that. Today I'm wearing my baseball tie because it's the opening day for the pitchers and catchers. So you've got to pay attention to these important things.
You should see his socks.
Right.
God knows what else is going on under there, but the socks are any indication. I'm Tracy Bahl. I lead the health plan business at CVS Health. The health plan business is about $70 billion in revenue, serving principally health plans, insurance companies, other managed care organizations. And I've been with the company for about 4 years. I am a global EMBA class of 2004 at Columbia Business School, and really excited to be here. My apologies to those who were in the morning panel. I probably look a little familiar. I did that panel as well. You have to suffer through a second panel with me, so I apologize for that. And I do think it's really neat that Bunny put a mild-mannered professor between the PBM and the
Well, first of all, who thought that pricing panelists could be this funny, right? Yeah, so we're going to have a good time. Number 2, thank you, Tracy, from the bottom of my heart. I had wanted Tracy all along, but they got him in the morning first, and I didn't want to impose upon him. So we were going to have somebody else from a large health plan, United, who unfortunately had to cancel on Wednesday. And so I sent out the clarion call to Tracy, who was nice enough to say yes. So thank you very much. And actually, it turns out this is great. Because you represent, each party here represents a different part of the system. So I'm just going to set it up with a few. This is a data-driven healthcare conference, after all, so I wanted to give you some data. So first, this article appeared in 2003 in Health Affairs, and Professor Anderson was the lead author. This was in 2003. It's The Price is Stupid. Why the United States is so different from other countries. Well, 15 years later, we have the exact same scenario. Why the U.S. spends so much more than other nations on health care. And it turns out in I guess just very recently, the Healthcare Cost Institute, for those of you who are interested, put out a report on our spending in 2016. So the facts are $3.3 trillion, 18% of the GDP, and last year grew faster than previous years. And so oftentimes what we hear is it's overutilization, it's unnecessary testing, it's a certain part of the industry. Well, it also turns out that when they looked at the data, the utilization was either flat or decreased. So at the end of the day, really, it was pricing. It was all about the pricing that accounted for most of the growth. And it was led by a number of different sectors. It was led by, in this particular year, it was led by outpatient ER visits, outpatient surgeries, inpatient surgeries, and then infused drugs. So and then just, 2 days ago or a couple of days ago, I saw this report, thanks to Pat, that says over the next decade, and this is from CMS actually, from the actuary's office, our spending is going to continue to increase at least 5.5% over year, bringing us to almost 20% of the GDP by 2025. Again, as you can see, pricing is a key component, but yes, there will be utilization driven by an older and aging population in Medicare and some additional issues. So before we get into the Q&A, I just want to show you, and again, this is from CMS, the Center for Medicare and Medicaid. This is how spending is today, and you can see hospital care is about 32%, physician care. Oh, I actually have a pointer. Let me see. Yeah, look at that. So hospital and physician is about 50%. RX is 10%. Now, that's somewhat understated in terms of drugs because in the hospital portion, you also have drug spend. But drugs are not the only thing driving costs, as you can see in this scenario. And then in terms of who actually pays in this country, you can see that state and local and federal, that federal meaning pretty much Medicare, state and local meaning Medicaid, is almost 50%. Household private is almost 50% too, and that's a combination of like insurance, employer-sponsored insurance, but also individual payments. So finally, how does the U.S. compare, as Jerry and his colleagues looked at many years ago? How do we compare to the rest of the world? Well, you can see we are much higher, and the proportion that we spend is much higher. So with that in mind, let's get started. I figured this would be better. All right, so given that we see the stats, I'm going to let the good professor start with this one. So every component of healthcare is more expensive in the United States and elsewhere. What is it that is driving these prices, Jerry?
So basically when I went to Washington, I basically was in charge of hospital cost containment in the Carter administration, and then in the Reagan administration helped bring you the DRG system. And I kept wondering, why were we spending so much higher prices than other countries? And do we have more services or not? And basically what we found is no, we don't have more services. We don't have more doctors. We actually have fewer doctors. We don't have more hospital beds. We have fewer hospital beds. We don't have more nurses. We don't have more what economists call real resources in the healthcare system. And so then we wrote this paper, and then we've been on this quest to try to understand why. Is it the result of malpractice insurance? Is it because of the way we train physicians and make them pay for tuition in the United States where most other countries don't? We had a whole laundry list of activities that we thought. And I'd say we basically have rejected almost all of those. And so I'm still coming up with one, but the one, and since I'm at a business school, that I'm most interested in getting your reaction to is when I look at the prices that the public sector pays and the prices that the private sector pays, private insurance, there's a 50% differential. Private insurance to doctors, to hospitals, often for pharmaceuticals, is paying 50% more than what the public pays. And as a result, I'm totally interested in why business is paying so much higher prices for the same goods and services. And I'll stop there, but I have some ideas as to why.
Tracy, do you have any thoughts on that?
Well, and to some degree, they don't have a choice, right? It is a function of cost shifting that takes place because those same providers are accepting less on their government lines of business, shifting more to the private lines of business, and as those lines of business grow disproportionate to their overall reimbursement mix or revenue mix, that problem gets even more exacerbated. It isn't right in its face, but it is to some degree something you don't have much of a choice about.
Patrick?
Well, I think your question was originally why are prices so much higher in the U.S.? I mean, I think there's some obvious answers, which is that most payers in the other developed markets are single-payer systems. So when we go to try to ensure that a patient has access to our lung cancer medication, we have a single purchaser who can really sort of call the shots and has all the leverage in the world, so that you're obviously at a bargaining disadvantage. And on top of that, there are some policies, at least around drug pricing, I don't know about other parts of the healthcare system, that reference lowest prices in other countries, which sort of reduces value and revenues in ways that we would think is somewhat irrational and doesn't reflect the value of the product. And I think finally, I mean, European countries have a different set of priorities. They try to spend their money in different ways. And if we want to talk holistically as a society about putting more money upstream to the other environmental and behavioral issues of determinants of health, that's one thing. I mean, I'm all for discussing anything like that as long as it's holistic. It's not, sort of vilifying one aspect or one part of the healthcare system. I don't mean to seem defensive, but I think in some ways a lot of this is headline driven, and we really fail to see the whole big picture and recognize some of the obvious facts that pharmaceuticals are 15% of the pie, branded pharmaceuticals are 7% of the pie, and when you look at overall healthcare spending, it's up 5.5% in 2016, up 1.3% for pharmaceuticals. So you have ESI, which is a competitor of Tracy's company, which says they reduced or they kept drug spending up to 1% increase last year, and I'm sure CVS probably is a similar number. So I mean, I think that there is a healthcare crisis, but it is a holistic picture, and it isn't really about overspending in the pharmaceutical sector.
Mm-hmm.
So you don't want debate, but let me.
No, I do want debate. I just want civil discourse.
All right, so
that's
civil
all.
discourse. So let me react a little bit to what Tracy said about cost shifting. And being in an academic institution or any hospital, or as you think of any physician, whatever money they receive, they're going to spend. And that's going to become their costs. And so if the Medicare program pays less than the private sector, they're going to take a look at how much they get from the private sector, how much they get from the public sector, say, how much money did I get? And therefore, if the public sector is paying less than the private sector, the public sector is always going to have a lower cost structure. And so therefore, it's obvious that, yes, there's cost shifting, but for me, it's because the private sector is paying more, not because the public sector is paying less. And to do what Patrick is saying, what essentially, if you look at what the public sector in the United States is paying, and you compare it to what is happening in Europe, they're not all that different.
Right.
For doctors and for hospitals and whatever. What makes the United States unique is how much the private sector is paying for the health care that they're receiving. And I think as business people, you essentially say, I'm going to look at my widgets, I'm going to look at everything, but you don't seem to look at how much you're paying for health care, the prices that you're paying, not the quantity. And so we work with a lot of business groups, and they really are focused on utilization. They're not, and value, but not on price.
I think that's right. I'm interested, though, do you discount this notion that there's cost shifting, not just on the domestic scale, but on a global scale? Pharma manufacturing, and I think there's merit to this, will often say we have to recover the enormous investment we make in research and development in the United States because we can't recover it from the public sector in the United States or almost any other economic environment outside the United States.
So yes, I totally agree with you that they don't seem to be able to do that. Basically the Council of Economic Advisors just came out a report last week saying, and the solution is to tell other countries to pay more. Well, that just doesn't strike me as a viable strategy. So, what do we say to, the industry about the fact that, no, Europe and Australia and places are not going to pay more. So what do we do to keep the industry afloat? I mean, when I talk to the members of Congress, especially the most conservative members of Congress, they're very concerned about the fact that the prices in the United States for pharmaceuticals and for hospitals are so much higher than other countries. And they don't think that's fair, and they want to do something about that problem.
Well, okay, right. I think all of us think it's not fair, but how did... like when you get a hospital bill, if you've ever gotten an EOB, which everyone here has gotten, and you can't decipher it, number one, but number two, an or a procedure that, costs $15,000, or a hospital, the stay in a beautiful hospital room is $25,000 a night. How did that come to be?
So if you look in the United States, our prices are about 50% higher for that same hospital day as it is. And in fact, in Germany, it's 1/4 the price of a day or a visit in the United States. Most of us don't believe that it's because the quality is substantially less or the access is poorer in those countries. We don't see any evidence of that. Part of it is that we get a different bundle of service, and it's really hard for us as researchers to try to figure out what's the bundle of services you would get in the United States versus the bundle of services that you would get in other places. But a lot of it is just the salaries that the physician makes, that the CEO of the hospital makes, and those types of activities. They are just so much higher in the United States. And the question is, to get that talent, do you have to pay those higher prices to the CEO of the hospital because they couldn't do something else? And so that's the challenge that we have.
I was just going to say, I noticed too that there's really a great deal of research interest in the pharmaceutical industry, the business model, how it plays out in the channel, and that's fine. But there just seems relatively little of space, energy, money towards that. The hospital, the bigger 85% of the healthcare spend, and it maybe I'm wrong, but if
you're right.
That's true, is that about just the difficulty of the data, or why aren't there armies of researchers sort of trying to get beneath that?
I'd like to suggest another vector here. In most of these comparative economies, you have almost a unilateral alignment of incentives, sometimes because there's only one payer. Mm-hmm. In the American private healthcare system, there is a grotesque misalignment of incentives. Virtually every step of the care delivery chain is opposed to each other, from the payer to the provider to the consumer, right? The payer wants to pay a lower rate to the provider who wants a higher rate, and they're pitted against each other, both from a price and utilization standpoint. Consumer wants an enormous amount of care, and the payer and provider want to give the appropriate amount of care. They are pitted against each other, and the arcane economic construct that we invented. I was in a payer most of my career. I've only been in pharmacy services for 4 years. So I'm a recovering payer, and I apologize for what I've done to you all. But we invented these arcane benefit plans that mean nothing to anybody and pit us all against each other. And I have directly observed, not at an empirical level per se, but directly observed how that drives costs in the healthcare system. Now, it served its purpose at one point, right? Back in the early days of managed healthcare, when we were all taking arrows for the first HMOs and the first managed care plans, that came at a very meaningful benefit to overall cost and price. If you look at the price vectors from back in the 80s, there was a meaningful price reduction as the result of managed care. Since then, that sort of adversarial model has, I believe, run its course. Now, there is a early and sort of promising development of a alignment of incentives through value-based contracting between PBMs and pharma manufacturers, between payers and their care delivery providers, and in consumer-directed plans that align economic incentives between the consumer and the payer. Mm-hmm. Does that hold any promise, or is it just me hoping for wishing for a better day?
Well, it does offer promise, but we just don't know how to measure things like value.
Yeah.
We just don't have any agreement among researchers, among clinicians about how do we measure value. And everybody does it differently, and therefore when we say we want value-based purchasing, it's a challenge. Let me just talk about Patrick's great question about why don't we do the same thing for hospitals or physicians as we do for drugs? And the real difference is we can say for drug A, it's exactly the same drug in England and the United States and in France. Mm-hmm. We can compare those. When I try to research what's a hospital day in France versus a hospital day in the United States, they are very different. Mm-hmm. Yeah. Even a doctor visit in the United States and a doctor visit in France are very different. Mm-hmm. So if you look at Japan, for example, they average 16 visits per person per year. We average about 3.5. They are 5-minute visits. Mm-hmm. Our visits are short, but they're not 5 minutes. Mm-hmm. And so what you got in that interaction with your doctor in Japan or the United States are very different. So it's really hard for us as researchers. I've been on that quest to try to do that, mm-hmm. and we just don't know how to do it so that it's really comparing apples and apples.
Well, you're not retiring anytime soon, right? So you still have time. I'd like to get back to Tracy's question, which I had that very same question, which is, we have a whole bunch of new payment models today, mm-hmm. right? Some of them are like, regurgitated capitation in some ways, but saying, value, you're right, very hard to define that. But it's not hard to define a bundled payment, right? Mm-hmm. And it's not hard to value like certain contracts. So, Patrick, I know that Merck is involved in some of these value-based contracting. What's your experience been with them, or Merck's experience, and where do you see the future of that?
Yeah, well, actually, this is about data, right? This whole
It is
meeting.
about data.
And I think we find that one of the most daunting challenges is the data piece to, ensure that we have the proper outcomes recorded and that we're collecting them. We find that perpetually that is an issue with payers. But I think they hold a lot of promise for just the reason that Tracy said, that they are aligning incentives in ways that really haven't been the case at all, so that the physician is being reimbursed and the payer is being reimbursed in a way that is aligned, so that the patient benefits in a demonstrable way. So we're all about that, and we have one of our chief people who are in charge of it in the audience here, Laura. And I mean, we're devoting a lot of resources to it because we think it is the way.
We'll quiz you later.
Yeah, we're gonna ask you some questions. Come on up here. All right. So we think that's the wave of the future, but at the moment it's a small part of the business.
Okay. What about you, Tracy, with CVS? What kind of payment?
Yeah. So we think about value based along a progression, and in the pharmacy realm, really formularies, if you're familiar with that construct, were the first value based models, right? We believe that this lowest tier provides the same clinical outcome as these that are much more expensive, and therefore it is value-based. So it's really the first primitive form of value-based contracting. We have evolved into relationships, and Merck is one of the companies we are doing value-based ideation with around the next level of conversation, which could include indication-based, which is basically one step beyond formulary, right? This drug is capable for a broad therapeutic category, but for one particular use, it's even better, and we're going to provide incentives for that particular use and maybe less for use outside of that. Broader outcomes-based, which is more classic value-based contracting, which you've heard about, which is find a population, either a population or a particular disease state like hepatitis C, and let's together define what a good outcome is. This is where defining value becomes really challenging, to Patrick's point, in part because there are so many variables acting on that patient. The payer is going to want to take credit for that outcome. The PBM is going to want to take credit for the outcome. The manufacturer and the drug is going to want to take credit for that outcome. Who proportionally delivered that outcome, and how should that value be shared? That's the arm wrestling that takes place. The final state, from our perspective, is essentially capitation. Now, PBMs, pharmacy services, is one of the last vestiges of fee-for-service in healthcare. And I will assure you, you do not want to be the last vestige of fee-for-service in an economic healthcare system, because everyone else in the system is aligned against you. They're all aligned, and they're taking all the value out of the system and keeping it for themselves. You're not sharing in any of that. You might want to be the second to last because you're milking that system, but you don't want to be the last one. So we have been quite aggressive about evaluating per member per month type capitation arrangements where we take full risk for pharmacy costs, knowing that when we work best, we're dispensing more medication, in part because patients are more adherent, right?
You know what? I bet not everyone here knows what capitation is. Can you just explain it?
Instead of being paid per drug, which is kind of how we're paid today, we're paid a flat per member per month, or per capita, per capitation, for each patient that we're covering, no matter how many drugs they use.
It's how managed care works.
It's and a lot of that is done on the medical side today, and rarely has it ever been done on the pharmacy side, and not at scale. So this is kind of an interesting company. We take a fair amount of risk then, and again, we're taking risk for a segment of costs that we actually want to increase. Most of us do, right? If you know the stats as well as I do, probably 25% of patients fail to fill their first prescription for any number of reasons. Of those that fill that first prescription, 50% of them fail to fulfill their treatment program. That cost is about $10 billion to the economic system in the United States, just by being a lack of adherence to your treatment regimen. So if we get people to adhere, they actually cost less money on the medical side and are healthier and happier. So we're taking risk, and we're actually going to raise the cost. So we take some incentive on the medical side as well. So we say, look, we'll take, instead of $500 million that I might take from a health plan each year, I'm going to take $20 per member per month, no matter what that is. And I'm going to distribute all the pharmacy services that your patients use. And if I'm successful, I'm going to lower play a role in lowering your medical cost. So I get a little bit of recognition over there as well as part of our contract. So that's a construct that really hasn't been used a lot in pharmacy. It's been used everywhere else. For those of you in health plans or on the delivery system side, it's been used everywhere else, but it really hasn't been used in pharmacy. Coming back to the original point, an economic alignment of incentives. And now I have no incentive whatsoever to shroud in opacity the costs that our health plans see. They see everything. They see everything, because I want that number to be as low as possible, right? So
let me follow up on Bunny's question and be a little bit controversial here, okay? So the question for me is about bundled payments. And it's not about capitation, but bundled payments. And in bundled payments, basically you give a provider, it could be a hospital, it could be a physician, it could be somebody, a certain amount to take care of you for a particular episode. Hip replacements, knee replacements, those types of activities. Historically, the doctor has been part of the bundled payment, the hospital has been part of the bundled payment, the home health agency has been part of the bundled payment, but prescription drugs have not. And so the question that I have, and I have two people on both sides of me, and I'm sure excited about this, it strikes me as if I have somebody who I want to determine the value, I want my physician to be the one who's determining the value, not a PBM, not a drug company. I want my doctor to make the decision about value. He might or she might not have the same measure of value. I could find another doctor. But for me, the entity that makes the most sense for me is the provider, and therefore bundled payments is the way for me to go.
Well, I would just say a couple things about that. I think we are generally in favor of adding drugs to the bundle payment, but there's a couple of caveats or things to think about. So I think one of the critical problems in the healthcare system is the disconnectedness between who's paying and who's benefiting sometimes. So, for example, the Medicare D plans that are standalone drug plans, there's no incentive for them to pay something that will benefit the patient on the medical side, just purely financially. And even in the plans that do the Medicare Advantage plans that are drug and medical, still they may not see the benefit of, say, a Hep C cure for 20 years. So you have a time problem, you have a movement of patient problem. So the only point I'm making is there has to be a way for that value to be incorporated, so that when the physician bundle is calculated, there's a recognition that if the bundle is for a patient with hepatitis C, that you may pay up front more than you're comfortable with, but in fact that has a lifetime of legacy benefit. So as long as those pieces are connected appropriately, and that you were linking up the true value of the product downstream, I think that it makes all the sense in the world, because there really should be a complete picture of what the drug and the home health and everything together. We have a number of products, or a product for C. difficile, for example, where the hospital pays. That causes diarrhea and very serious complications for elderly patients often. But the problem is that the hospital pays for it in a way that actually doesn't benefit that particular hospital, because the patient will not be readmitted, but they might not have been readmitted to that hospital anyway, or they may get paid. The hospital may get paid again. So to have something that recognizes that the whole healthcare system, not to mention the patient, is benefited when their C. difficile is finally cured and they're not going to the hospital 5 times for 5.
Alignment of incentives.
Alignment of incentives, exactly.
Yeah. And I agree 100% with Patrick and with Dr. Anderson. I would welcome the opportunity for pharmacy services to be included in bundled payments. It is consistent with the directional belief we have around the capitation model I was describing before, and would further agree with Dr. Anderson that the best person is your physician when determining value. I would caveat that by saying the best person to determine value is a fully informed and properly incented physician. And that is not a derogatory statement toward how they behave today, because we've really messed with them, right? Yep. We don't give them enough information. It's really hard for them to get it. What we do give to them, we bombard them with alerts on their EMRs that are mind-numbing, and we've messed them up with incentives all over the place, right? In some books of business, they're incented to do one thing, and others are not. In some cases, the dynamic that Patrick just described, what they do well, someone else benefits from. Alignment of incentives, and then proper information that helps inform their decision-making at the point of care. In our pregame warm-up, we were talking about something we're doing, and this is not an ad for CVS Health, but it's an example of what we're doing. We're doing something called real-time benefits, which leverages our connectivity with the care delivery system through Epic or SureScripts, two connectivity platforms, to push to the point of prescribing for the physician a set of choices based on the therapeutic category or prescription they're about to make, that allows them to look at what might be the best choice for that patient therapeutically and economically, considering all factors: prior prescribing history, other medical conditions, their benefit plan, and other options available to them outside of their benefit plan. And it puts it right there to say, hey, you just prescribed this medication. Here are 3 others that might be therapeutically equivalent and lower cost for that patient. That same information, now, that's informed a physician. Now, that physician may say, I know that, but I feel strongly about this medication. I'm comfortable with it. All my patients use it. They've had good luck with it. It's going to cost the patient a few dollars more. I'm willing to justify that to my patient. But I'm informed now. And that's a small, tiny little thing, but it hasn't happened before because all those pieces of information have been so hard to get in one place. And then we're putting that same information at the pharmacy counter. So when you show up at the pharmacy counter and the pharmacist says, that'll be $750,000 for your prescription, you go, whoa! And they say, well, call your insurance company. We don't know what's going on. Now they'll be able to say, well, yes, it costs that much for this medication, but your insurance company covers 2 more that are considerably less expensive, and it's the same data that the physician was seeing, it's just presented a little bit differently. And then the consumer will have the same thing on their phone. So over time, we hope we can start to align incentives and provide that same kind of actionable information at the point of decision making that's useful and allows them to be joined together in how they make that decision.
I do want to talk about employers because clearly employer-sponsored insurance is a major way that many of us get our health care in the United States. And employers for years have been trying to address this, the Leapfrog Group and other, the Northeast Business Group on Health, et cetera, et cetera. Well, a couple of weeks ago, we heard a big announcement from Amazon, JP Morgan, and Berkshire Hathaway about their potential attempt to address this issue. And just wanted to get your thoughts on it, where you think that may go, how that may, and realizing that we know nothing at this point. We know nothing, but would love to hear your thoughts about why they even came out with this.
I can start if
go.
you like. Well, first, if you look at the spirit of what they're challenged with and what they want to accomplish, we're completely aligned. I think we probably all are. We're all frustrated by the challenges they're facing, and we really want to change that. And if you've got 3 very large companies with lots of employees, diverse workforce, and some pretty smart people joining in the fight, welcome to the battle. I think that's fantastic. Second, we do not know what I'm not even sure they do. So right now you got 3 big companies with a lot of money, a lot of employees, and some really smart people that want to do something about healthcare. Great. The people they've assigned to it, from a leadership standpoint, sort of have a benefits and orientation a little bit. So it may feel more like a purchasing cooperative or a health transformation alliance kind of feel. It's hard to tell, but we think it could be a great partnership over time. Several of those are clients of ours and folks that we would love to be engaged with once they kind of get clear on where they're going to go.
So I don't think, I agree with that. I don't think any of them, even though as large as they are, have enough market share in any community to do anything meaningful. I mean, Amazon is not the major employer in Seattle. JP Morgan's not here. Maybe Berkshire Hathaway is in Omaha, but I'm not sure of that. Essentially, you have to have market share in order to have an effect. And they don't have market share in any community. So I don't see how just the 3 of them can do very much. I think, essentially you need the corporate America, and they could be the group to bring it together. But alone, they're not going to have very much impact. If they can bring Boeing and other places on their same platform, maybe. And I would hope they would, because as I started out my conversation with you today, I basically said the private sector pays 50% more than the public sector. And, they've got to do something. If they don't do something, if the private sector doesn't do something, as Bunny suggested, it goes to 20% and then 22% and then 26%. And by the time it gets to about 25%, all the productivity growth in the United States goes to health care. So you won't get raises, but you will have health care. And that's going to be a problem at about 24, 25%.
And I would only add that I've learned that healthcare is complex. I don't know if
Really? Oh, really?
Yes, well, just from these two, actually. I came in here thinking it was pretty straightforward.
Oh, you work in Washington. Oh.
That's why I come to these things to learn. But the only thing I think is the one issue I'm concerned about is it seems like every time somebody gets a bright idea to reduce costs, they put the burden on the patient, and they say, well, an informed patient actually will spend less. Yeah, they'll spend less because you took away benefits from them and you increased deductibles. So when you look at the rise in the premiums, and I have a nice chart on this, but you told us not to bring slides. Thanks a lot. But it looks like this. Healthcare premiums and out-of-pocket costs go like this, skyrocketing from like 2006 to 12. Do you want me to? I'll stand up and do it. This as an industry, as an individual as well, that's our issue that we need to get after, that patients pay way too much out-of-pocket for their pharmaceuticals. My personal view and the view of many is that that's why we are such a lightning rod in this industry, frankly. The patients pay upwards of 20% for their out-of-pocket associated with pharmaceuticals, where it's about 3% for hospital care, notwithstanding that it's a source of bankruptcy and such. So there's some policy choices they're making in Washington. Alex Azar, the new CMS director, is talking about an absolute cap, at least in Medicare, on out-of-pocket spending. And I think it's got to start there, because it's just crazy when you see, like you were suggesting, Tracy, you see utilization drop significantly in the first 3 or 4 months of the year because patients are in their deductible, and then they reach it, and then they go back on their meds. No sane policymaker would have ever designed something like that. So I just hope that we're talking about a more holistic solution and not just putting things on the backs of patients like we have in the last 10 years increasingly.
Well, on that note, thank you.
Sure.
I want to leave time for Q&A. So would anybody like to start? Sure.
Hi, my name is Peter Kerr, and to paraphrase Tracy, I'm a recovering New York Times reporter. Covered healthcare for one time. And I apologize. But my question to you is, how has the media done on pricing in, say, the last 2 years overall? And what would you suggest are the stories they haven't covered that they should?
Good point.
You mean pricing across the board, right?
Across the board.
Oh,
But if you want to focus on drugs, that's fine.
Yeah. Well, I don't know. I mean, when I look at something, I might be saying something tendentious, but when I look at like the Hep C thing and the $1,000 a pill thing and such, and without people recognizing what's happened in that space in the last 2 or 3 years, that 8 years ago, if you had hepatitis C and were facing the prospect of liver cancer and such, you had one choice. It was pegylated interferon and ribavirin for 48 weeks. It felt like the flu and depression combined for 48 weeks, and you had a 25% to 50% success rate, and it cost $30,000. Fast forward to today, I'll spare all the intermediate steps. The state-of-the-art product is a product by AbbVie. It's $30,000. I'll average 8 to 12 weeks of therapy, nearly 100% cure rate, and it's 12 to 24 weeks of a couple of pills a day. Same price. So in the course of 7 years, we've taken this pill, this dreadful disease, and taken it from almost impossible to get cured to like very easy for the same price. And yet we're smeared by this, this terrible shame to have created this breakthrough product that cures people. So I feel like in a way those stories would be great to hear. So I'm not overly thrilled with the way that things have played out, but I don't mean it in any personal way. But I mean, I think it could be a little more balanced, really. And I think most people, if you ask them, would think that drug costs are driving 95% of healthcare costs, and that is blatantly false. A little more context would be super.
Yeah.
Yeah, I would just add to that. And hepatitis C is a great example, but it's also sort of a singular example in many ways, because it absolutely cured hepatitis C. We don't cure completely many diseases these days. So it is, in many definitions, a miracle drug. And you could make arguments that it's priceless. However, when you begin to do some sort of pharmaceutical efficacy evaluation based on quality-adjusted life year, it pays very, very well. The end pricing for hepatitis C, as expensive as it was, actually appears to be worth it, believe it or not. I think the other story that is often missed, and it's one we talked about in our pregame warm-up, is if you look at gross pharmacy trend, right, the sticker prices that get all the headlines, they're in that 10 to 13% range, double digit, low double digit, right? If you look at the net price that those with insurance coverage are paying, and we mentioned Express Scripts at about 1.5 points. We'll announce ours in a couple weeks. It'll be in that ballpark. Ours will be lower as well. There's a huge delta between the gross and what people are actually paying. And that money is an absolute 100% discount off of what he charges. So he isn't getting that much. The pharmaceutical manufacturers aren't getting that much. They're at discounting way down here. So they shouldn't get beat up over that. And those that with coverage are paying at a 1.5 to 2% rate of inflation. If you take utilization out of that trend, which is about 50 to 100 basis points, you're well below the pace of inflation. So one might ask, where's the problem? Where's the problem with drug pricing? Well, the problem comes in a couple places. Number one, the people who are paying off a sticker price, the people who are paying off gross. And those are the uninsured and those in the cash portion of their benefit. Those are the people who really need help. So you see programs coming. Ours is called Reduced RX. There are other examples from other PBMs and other pharmacy chains where we're negotiating low-cost alternatives for people in that portion of their benefit. Manufacturers are providing coupons that provide help there. Community-based services and foundations are providing assistance as well. But there's more that can be done there. The other area that gets the headlines is brand new drug introduction. Again, hepatitis C is kind of a one-off because it cured stuff. Others, you have to get into this idea of how much is it worth from a medical efficacy standpoint? How much is it worth over time? And then you get into the very social debate about what is the price you put on, how much is life worth? We tend to think $100,000 quality adjusted life year, but there'll be people who would debate that. So it's a really challenging kind of social conversation to have. The last area that get the headlines, most of it's gone by now, are the pharma bro activity where it's it's just opportunistic hedge fund type approaches to buying an undervalued drug and pumping it up. Most of that has been shamed into quiet non-existence.
Well, I have a good story for you, actually, and it's Dr. Anderson. You are publishing, why don't you talk about your 25th anniversary?
Oh, it's not coming out yet, so we can't talk about it yet.
Oh, talk about gun jumping.
No, it's coming.
Wow.
You can't do a little plug?
It's coming out. So this is an article that took the 2003 and did it again. Uwe Reinhardt was one of our co-authors on the paper, and he died recently, so we're doing a tribute article to him and updating the thing. So that's what Bunny is talking about. Two areas that I would focus on if I were the New York Times reporter. The first one is really the mismatch between who pays and who benefits. So think of a prison who's got a lot of people with hepatitis C. Why would they spend $25,000 or $20,000 for treating somebody with hepatitis C? It's an infectious disease. It kills more people than AIDS. It's the infectious disease that kills more people. But if you're a prison where a lot of people have it and then they leave the prison and they bring hepatitis C out into the community, they're not going to spend $20,000. How do you get, because it's not worth it for them because the person could be in prison for 5 years and isn't going to do that. We are talking to CMMI, Medicare and Medicaid right now about covering everybody in the state of Maryland for hepatitis C because the benefit occurs when you become 65 or older. And whether or not we can convince them on a population health to do that will be an interesting story to do it when it actually happens. But that's what we're trying to do. The other thing, and again, I don't want to sound like a broken record, but I would love to ask any CEO of any major corporation, why are you paying so much more than Medicare for the same thing?
Do we have any CEOs in the audience? All right, do we have more questions?
Hi, yes, thank you. Amy Allen. I have a question. I think it speaks to Bunny's question about what employers are doing to change the dynamic. Several employers are now starting to enter into direct contracts with healthcare providers. They're going to their hospital or their physician system and just saying, I'll give you X dollars, you take care of my employees, whatever it costs. Curious if you think this is going to be a trend, if it's only for large employers, what you're seeing.
So it's a trend that was a long time ago. So if you think of how Kaiser Permanente, for example, got started, it got started because there wasn't any delivery system where they were building the Hoover Dam, and Kaiser was the one who was building it. And if you think about, a long time ago in any country, any rural community where there was a factory, there was the place where the doctor was, and he was employed or she was employed by the thing. So this is a return to the 1900s, essentially, to do this. I don't see that it's a major issue. I mean, the administrative services only contracts that the large employers get are 6%, 5%, 8%. You could cut that out maybe, but you'd still have to pay these doctors and do these kinds of things. So I don't see it as a major cost reducer, but it's something to consider. And remember, when we had those in the 1900s, the doctor had an incentive you didn't trust your doctor when you went to the clinic because they were working for your employer.
Mm-hmm. Mm-hmm. Yeah.
More questions?
Does anybody else have a mic? No? Okay. I have two questions. Hillary Nierenberg, I'm a hospital executive from a large healthcare system, and I'd like your opinion on whether or not you think the lack of interoperability between the large EMRs that we have is contributing to the utilization, lack of communication, and whether or not we should be looking at technology, a solution out there that would provide interoperability. And then the second question would be whether or not you think that with the aging demographics, how we deal with end-of-life issues is something that also should be addressed at some point on a larger scale. It's a tough conversation, but where it fits in.
So if you look internationally on interoperability, it's a problem in most countries where there are multiple people providing the services. So, I mean, if you wanted to solve it, you'd say to Epic or Cerner or one of them, you've got the whole business for this community. And we've seen that in certain areas in other parts of the world where they have done it, and that's worked well. But that's not America. That's not, trying to provide the competition. So, but that's, if you wanted to solve the problem. I spent a lot of time with David Blumenthal, was the first person who had to try to solve this problem in the federal government. And basically, the system didn't work very well for him. He couldn't make the system work to get interoperability because the different things wanted to differentiate their product. They didn't want to have the same product. In terms of the aging demographic, we are a young country. We are 25th among the industrialized countries in the percentage of the population over the age 65. We have about 14%. Japan has 26% people over the age of 65. Italy has 19%. These are the countries that we should be looking to, and in terms of end-of-life care, in terms of chronic care, in terms of all these kinds of things. They're working on solutions to these problems, mostly by allowing people to remain in their homes as opposed to getting into nursing homes, because nursing homes are about twice as expensive, and people would rather be in their home if we can make it possible for them to do it. So in Germany, for example, you can go to a nursing home and it's going to cost the German government about $80,000, or you can take a cash payment for $40,000, and most people choose the cash payment of $40,000. We've experimented with this a little bit, but not so much. The same thing with hospice care. We haven't done it very well compared to other countries.
I would just add on the interoperability, we're and this is not a plug for Epic, but we're on the Epic platform as a company, as CVS Health. We're the largest, apparently, client of Epic's in the country. And we chose Epic in part because it is interoperable with about 90% of the EMRs installed in the marketplace today. Now, I think you would agree with me, interoperability, there's interoperability, then there's real interoperability. And, Care Everywhere starts to get a little bit in that direction. I haven't given hope on that. I think it is part of the fragmentation that we've talked about before, alignment of incentives and getting information real time that's usable at the point of care. I think interoperability radically accelerates that, and I have not given hope that we can do that. Now, we're doing it through Epic, and we invested a lot in a joint venture with them, doing some collaboration on different ideas. The real-time benefit thing I described earlier is through that platform. So little things like that hopefully move us along the way. I think Dr. Anderson made a great point. In this country, while we probably skew well below other nations, we've got this big bolus coming, moving through the system, and that's going to challenge a lot of the care delivery environments today, particularly post-acute. And I think there's a rich opportunity to address the post-acute marketplace as these highly complex patients, highly vulnerable patients come through this system. It's putting a lot of stress on payers and providers. And most of our clients, health plan clients, will say, I'm pretty good in the inpatient setting. I've got hospitalists, I've got good visibility on the data, I know what's happening inside the acute setting. The minute they're discharged, their transitions of care become so frequent. They go into the skilled setting, then the institution, then they go into the home, and then they go back into the acute setting, and then they go, and I lose them. The care gets fragmented, I lose continuity, I lose quality, and their lives are hell. I really need help in that environment. I think there's a rich opportunity there as this bolus comes through.
So I think there's part 2 coming of this panel. So I want to thank Patrick, Dr. Anderson, and Tracy so much for today's panel. Hopefully you all got a lot out of it, and look forward to seeing you in a few minutes at our fireside chat. But thank you so much.